I'm sure that Professor Bere went deeply into the details of laser Doppler flowmetry, so I don't want to talk too much about it. I just want to show an example how we can use this technique in the clinical field, or how can you perform a study with the laser Doppler flowmeter. So what about the microcirculation? It's, as you may know, it's responsible for tissue oxygen and nutrient supply. There are a lot of transport through this part. It's an immunological consequence if you think about the transmigration of white blood cells from the bloodstream into the tissue during inflammatory reaction or inflammatory substance production. And there's a really special part, a really special organ, the skin. I don't want to go into the deep details of the anatomy of the microvascular structure of the skin, but 85% related to the thermoregulation and only 50% to the nutritive function. Why skin is so important for clinicians? Because there are a lot of acute or chronic disease or state which cause microcirculatory dysfunction or damage. And in these cases, the healing is prolonged. We have really large amount of complication, infection, necrosis. As you can see, for example, diabetic patients with diabetic microangiopathy, there is a really big problem. This is a chronic ulceration or life-threatening state burn wound. Or for example, this is one of our patients who underwent chemo irradiation, but afterwards we have to operate this patient, and just imagine the healing tendency, such a tissue with a lot of fibrosis. It's really bad, so the reconstructive surgery is really complicated and the healing period is prolonged. Fortunately, this patient healed afterwards, but it took for a lot of weeks. So that's why it's so important, and how we can test or measure the microcirculation with the non-invasive method, with the laser Doppler flowmetry. It's really easy to use, it's non-invasive, and you can measure the initial state of the patient. You can use different treatments and test the effectivity of this treatment. You can check the regression or progression of a disease, for example, diabetes. You can use it for clinical follow-up and, for example, intraoperatively to test tissue vitality. And just a couple of words how it works. This is the laser Doppler probe, which emits the laser light into the tissue. Large amount of this laser absorbed in the tissue, but some part reflected back from the moving particles, from the moving red blood cells, and during this reflection, the frequency of this laser light shifted. This is the so-called Doppler shift, which correlates with the blood flow. So basically, that's the background. To measure only baseline blood flow, it has not that much information. I will show you later on why not. So we have to use different reactivity tests. With these reactivity tests, basically we force the microcirculation. We use different stimulus to cause hyperemia, for example, and the level of the hyperemia correlates with the compensatory capacity of the skin. For example, with the post-occlusive reactive hyperemia test, we use a cuff. We increase the pressure above the systolic pressure, which basically occludes the vessel in the lower arm. This is the baseline. This is the perfusion during the occlusion. And when we release the cuff, we have this beautiful hyperemic flow response. And we can calculate the latency from the occlusion to the peak, the latency from the peak to the recovery, the area under the curve, the slope so on. So there's a lot of information in one single report. For example, in diabetes, this beautiful sharp peak disappears, the peak flow is reduced, and the recovery is prolonged. So in some diseases there are characteristic change in these reports. You can use the iontophoresis method. In this case, we use different vasodilators, for example, in this case, sodium nitroprusside, or you can use acetylcholine to induce vasodilation and hyperemia. You also can calculate the different things, as I already mentioned. Or we can use the local heating provocation test with a special probe, which heated by the equipment, and again you can calculate the flow increase and so. So what is the purpose to use this equipment? There's a special implant, the so-called bone and cord hearing aid, which is a bone conductive hearing aid, and we developed a new surgical technique for the operation, and we want to prove the advantages of the new method of laser Doppler flowmetry. So just a couple of words about this BAHA. This is the implant itself, which fixed into the temporal bone. This is the so-called abutment, which makes the connection between the microphone and sound processor and the implant. And in case of this type of BAHA, this is a so-called transcutaneous abutment. So you can see the end of the abutment here, and this is the speech processor. So historically, they operated this BAHA with a dermatome to create a skin flap, and then they removed the underlying soft tissue in the peri-implant area. It was necessary in the previous types of abutment because sometimes they cause tissue hypertrophy, and when the tissue is enlarged around the abutment, of course the outer part, the sound processor, cannot be attached to it. But what was the problem with this method? If we check the anatomy, you can see that we have to remove this part of the tissue, which contains basically the microcirculation. So, of course, it causes a lot of problems, microcirculatory impairment, healing problems, necrosis, infection, and so. But now we get new types of abutment, which coated with hydroxylapatite. These are tissue-friend coats and cause less soft tissue hypertrophy. So in that case, when we use this type of abutment, this soft tissue reduction was not necessary anymore. So we decide to change the operative technique and make a smaller incision, and we preserve the soft tissue around the abutment. And this is the result. It's only 15 millimeter, so it's really small. The whole operation takes only 15 or maximum 20 minutes. And if you compare the two surgical type, I think it's understandable why is it less traumatic and better. So the zero hypothesis was that this new technique reduces the possibility of late tissue damage due to minimalization of microvascular damage. And we tested the microvascular reactivity on patients underwent BAHA implantation. We use a local heating provocation test, and of course we followed our patients with laser Doppler flowmetry. We have 3 different groups. The first one operated with the previous technique, so this patient underwent soft tissue reduction. We measured the operated and the non-operated contralateral side. The other group underwent implantation with soft tissue preservation, again operated and non-operated side, and we have made controls who have no operation, and we measured both sides. We applied the perimet periflux laser Doppler started to heat the probe to 44 degrees of Celsius, and we applied 5-minute heating period. Baseline calculated as the 100%, and we calculated the percentage flow increase, which basically mirrors the compensatory capacity of the peri-implant skin. And what are the results? This is a representative record from a patient underwent soft tissue reduction type operation. This is a non-operated side, so the normal reaction, a really prompt, really high flow increase compared to the other side, where the hyperemia is relatively poor. This record is from a patient underwent soft tissue preservation. There's a minimal difference between the hyperemia. As you can see, also in the operated side, we can see a really prompt and relatively large hyperemia compared to the patient underwent soft tissue reduction. So this is the operated side after soft tissue reduction, and this is after soft tissue preservation. In this diagram, every dot represents one patient, the baseline flow, and the peak flow after heating period. And that's why I told you that a reactivity test is also necessary, because if you check the baseline flow in each group, it's closely the same. There is no significant difference between them. These two groups represents the non-operated patient, the naive group, and the contralateral side of operated patient. But if we go to the details and check the hyperemic response, you can see that patients who underwent soft tissue reduction, the peak flow is significantly lower. So that's why you should always use some reactivity test. If you compare the percentage increase of local blood flow, the result is the same. The patients underwent soft tissue reduction, the percentage flow increase is significantly lower compared to the other groups. So besides that we can shorten the surgical time, the soft tissue preservation reduces the possibility of tissue damage due to preserved perfusion. So we hope that we have less postoperative complication with this new method. We proved it with laser Doppler flowmetry, and our clinical observations prove the result of the measurement. Thank you very much for your attention.
Thank you very much. Now you can find some small cross-section for our clinical work for everyday life. Of course, I don't want to mention you for the laser pointer when we use every day because we have so many lectures. So it's nothing to do for the clinical practice. Now it's open for some questions. If you want to ask for some questions for our presenters, maybe if you need for some more understandable things, or maybe you want to discussing for something, of course it's possible. If it's not, I would like to thank you for all of our presenters and also for the organizers, listening for our interesting lectures. Okay. Somebody have some information or some question?
Yeah.
Okay.
Okay, I don't remember who talked about this, but I was wondering why in the stenosis problems, why the treatment is, why you treat most children instead of adult people? Because it is related to only to genetic diseases, or it can be caused by external factors?
Thank you for the question. The two causes, the congenital and the acquired cases, we both treat, as the first chart showed, we have elderly patients and also children. Nowadays, we have very good contribution with the pediatric clinic in the university, and we examine all children, all newborns who have problems with the breathing. And most of these cases are temporary things. So some 70% of the newborn cases are temporary, small things. The short of breath immediately disappears. So we may help the patient earlier without doing any interventions. In the first couple of months, the patient will breathe a bit strongly, will loudly, and after this will disappear. So, but now we have a chance and we have equipment, so that's why we're doing it immediately. And we also have the older patients who are acquired because of long-term intubation or after iatrogenic injuries, after, for example, thyroid surgery or the minor patients, so we have to operate both.
Thank you.
Some more? Of course, it's included, we have so many patients, not only for the very young, but it was only for this lectures being targeted only for the to helping for the very young child. If you have the upper area problems, because we have so many adult patients also, we have a different kind of trauma and different kind of the problems for that, but the most important to helping for the very young child, right? Okay. If it's not, again, thank you very much for your attention. Okay, I'm closing for the session now.